This is Chapter 13 out of your word, promoting patient comfort during labor and birth. So, pain during labor and birth. Everybody perceives pain differently. It's shaped by our past experience. Responses are all different. It's going to depend on how we tolerate pain. Pain may be intensified by fear, anxiety, fatigue. So, the physical causes of pain. We get pain from uterine ischemia. So, with every contraction, it causes pain impulses. We can have that visceral pain, which is that dull, achy type pain. There's referred pain, and that can go into the back, which we call back labor. It can go down the buttocks, down the thighs, and then there's that somatic pain. That's the sharp, burning, prickling pain. Again, pain is subjective. It's affected by gender, culture, ethnicity, past experiences, our physiological and affective expression. So we're going to have an altered respiratory pattern with pain. Our blood pressure is going to increase. Our heart rate is going to increase. We're going to get an increase in those catecholamines. So our personal factors that affect it, so physical, they found that women who have a history of dysmenorrhea have increased pain. Our physiological, for those that do natural birth, our body is amazing and it releases endorphins, and these endorphins help decrease the pain. The psychological, again, the anxiety, fear. Sometimes it's really scary if you're a first-time mom, not knowing what to expect, or maybe the mom has had a bad experience with the previous birth, and that initiates more fear. It's going to depend on the childbirth preparation, so if people have gone to birthing classes, that might be helpful. And then their support system. Do they have another person to be there? Environment is going to play a factor. If we can keep a calm environment, keeps the patient calm. So there's different theories about pain and pain pathways. The multidimensional phenomenon, this is all sorts of like the affective, physiologic, behavioral, sensory, and cognitive all impact the pain pathways. There's the neural pathway, and then the gate control theory, which is pretty interesting because that theory just says that there's only a certain number of pain sensations that can be felt at once. So they feel that by taking childbirth classes, you can help kind of control what sensations that you're feeling. So how can we support our patients? So some non-pharmacological, the maternal position and movement. We can keep our patient comfortable, work with them on their breathing, maybe put some nice music in the background. You could do some guided imagery. There's several different massage and touch therapies. Massage is, well, and remember, massage is comforting for some, but other people may not like massage, so make sure you're figuring out what your patient's preferences are. Therapeutic touch, healing touch can be used, and that's using the body's energy fields to heal itself. There is hydrotherapy, aromatherapy, hypnosis. You can use heat, cold, TENS, acupressure, acupuncture. So the pharmacological pain relief measures. Timing is everything. If you come in and you are, dilated to 9 centimeters and ready to have that baby, you're not going to be able to get, an epidural and that sort of thing. So timing is key. So if you can incorporate, based on the patient's preferences, non-pharmacological with those pharmacological measures, it's going to promote a positive experience. Know before you administer any pharmacological therapies, you have to have informed consent. There is several drug classifications. There is antiemetics that will help with the nausea, vomiting, barbiturates. They can use for sedation, benzodiazepines, but that's going to depend on the physician, because some physicians don't feel comfortable with administration of that. But that can help with decreasing anxiety, kind of provide some sedation, decrease the nausea, vomiting. So you can use systemic medications like opioids. There is nerve block analgesia and anesthesia. The regional anesthesia is temporary. You just want to make sure you have your emergency equipment ready. They can get what we call a pudendal nerve block, and that is a nerve that runs along kind of the inner thigh up by the vagina, and they can just inject a nerve block, and that'll only provide pain relief to the vagina, perineum, and vulva, and it keeps the patient comfortable without without causing a whole lot of side effects. There's a spinal block, but the complications are maternal hypotension, decreased placental perfusion, can have problems with respirations. So with that spinal block, they can have some leakage of cerebral spinal fluid, audio-visual problems. They'll have to maintain bed rest, apply cold packs, no NSAIDs for 2 days, and they'll have to watch for any neuro complications after they get this autologous epidural blood patch. So epidural, it's a local anesthetic. They'll have pain relief from both. It'll be injected into the epidural space. They'll have pain relief from both the contractions and the birth. They'll use an opioid and then a local anesthetic agent. So some of the advantages is there's no fetal respiratory depression, and there's minimal trauma to the fetal skull, but the mom can have some hypotension. But to prevent that hypotension, you can preload the patient with IV fluids. You want to monitor their vital signs, and there has to be someone with them all the time to watch them. But the disadvantages, they can accidentally inject it into a blood vessel. Again, they're not going to have that mobility. They're going to be able to move around a whole lot. They'll have some urinary retention, bladder distension as a potential side effect. There's some other nerve blocks they can get. They can get intrathecal, or general anesthesia. In general anesthesia, that will be for, like, if they have to do like an emergency C-section, but this produces major risks like the hypoxia to the baby, aspiration to mom. And again, it's just like, standard aftercare, just monitoring for nausea, vomiting, aspiration, making sure baby's okay, taking frequent vital signs on mom and baby. So comfort measures, we want to keep an ongoing assessment, potential nursing diagnoses, anxiety, acute pain, or maybe chronic pain if they have complications. They might have pain for a while. Ineffective coping. We want to reduce, as our expected outcomes, reduce complications, and make sure that our plan of care is individualized.